Hello my dear students, I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. What are we going to learn today? We are learning hip joint 2. Okay, so what have I covered already? In hip joint 1, I have covered another name for the joint, classification, bones forming the joint and ligaments forming the joint. I request all of you to go and take a look at that video. The link is given in the description section so that you are updated with the complete joint. Today, what are we covering? Today, we'll be talking about relations, movements, muscles. See how I put them together. Relations, movements, muscles. Because this is one package. You have to understand that today. Plus, I'll be talking about blood supply, nerve supply, and the very important applied anatomy. So let's begin then. Before that, again a little request. Like I'm sitting with this hip bone and femur, I request all of you also to sit with these two bones. It will help you to understand the topic much better. Right. So now suddenly you're seeing this big diagram on the screen. So many muscles and so many nerves. How am I supposed to remember, ma'am? I'll tell you how to remember. Okay. Just orient yourself once. You can see the acetabulum here. Put that in your brain. Use your fist. Come on, do it. Use your fist to act as the hip joint. Okay. So now think of this as your right hip joint. Okay. And what is lying in front of it? Can you remember? In this area was the femoral triangle. So all those muscles anteriorly, sartorius, iliacus, psoas major, pectineus, duct longus, everybody along with femoral artery, nerve, vein are all lying here. Please do this with me. Okay. Therefore, posteriorly, what should I find? I will find gluteus maximus, muscles deep to gluteus maximus. Correct? Okay. This, my wrist, is acting as adductors. Okay, so the medial compartment of the thigh, adductor longus, brevis, and magnus, gracilis, everybody is here. Okay, and here superiorly, superolateral here is your gluteus medius and minimus. Okay, put this in place and now using that wrist, come back to the diagram. Ready? Okay, right here in front of the hip joint are all structures which are related to femoral triangle. Sartorius, iliacus, tendon of psoas major, femoral nerve, artery, vein and so on. Therefore, these muscles which are medial should be adductors. Very nice. In between them, you will find your obturator nerve. Therefore, posteriorly, you will find gluteus maximus and structures under gluteus maximus. Superiorly, you find gluteus medius minimus and tensor fascia lata. Madam, what is the requirement for us to know so many relations? I'll tell you the requirement is because these are the muscles that are going to act at the joint. If you don't know the muscles, how are you going to know who is bringing about the movements? So you must be able to use this technique of mine. This is your hip joint, anteriorly femoral triangle, related structures. Posteriorly gluteus maximus, structures under gluteus maximus. Medially, adductors. Laterally, gluteus medius and minimus. Put that in your brain. Okay? Chalo, let's go ahead now and begin to talk about movements at the hip joint. Now you have to pick up your hip bone and femur and do the movements as I tell you. Ready? Okay. The first movement is flexion. Now pick up the femur and hip bone, articulate them. Okay? Now, whenever there is flexion, the femur will move forwards. Flexion. Whenever there is extension, the femur will move backwards. Extension. Now tell me, around which axis is this movement taking place? Around which axis is this movement taking place? This is taking place around the transverse axis, isn't it? So every time you do a movement, think of the axis around which the movement is occurring. Flexion, extension around the transverse axis. Next movement I want you to talk about is abduction, adduction. Take the femur, begin to carry it upwards and back, laterally. Abduction. Begin to carry it downwards and medially. Adduction. Abduction, adduction. What is the axis here? Can it be an anteroposterior axis? Okay, around which it abducts and adducts? Yes, so that's the axis. Now let's do the last action. What are these? Medial rotation and lateral rotation. When the femur comes forwards and medially, this is medial rotation. When the femur watch the greater trochanter. When the greater trochanter goes backwards and laterally, it is lateral rotation. Medial rotation, lateral rotation. What is the axis? It's a vertical axis. Okay. So let's revise this. Flexion, extension, transverse axis. Abduction, adduction, okay, anteroposterior axis. Anterior, posterior. So medial rotation, lateral rotation, vertical axis. Know these together. Okay. If you're done, keep the bones down. Let's now talk about muscles bringing about these very actions. Okay. Right. Now I want to show you something called as mind mapping. Okay. So I'm going to, in my mind, create a hip joint. I've already done this with the wrist with you. Here is your hip joint. All the muscles which lie in front of the hip joint, remember I told you femoral triangle region, all these muscles will be flexors. The muscles that are lying behind the joint, remember gluteus maximus, all these will be extensors of hip joint. All these muscles which lie medial to my joint will be adductors. All these muscles which lie lateral and superior will be abductors. Do this once again. Okay. This is your hip joint. If a muscle lies anterior to it, it will flex the joint. If the muscle lies behind it, it will extend the joint. If the muscle lies medial to it, it will adduct the joint. If the muscle lies lateral to it, it will abduct the joint. Use your God-given logic. Human body also functions on the same physics which was taught to you in your school years. It's all physics. So you have to use your logic where joints are concerned and common sense, which I always say is your biggest friend. For God's sake, don't waste your time mugging up actions and mugging up muscles bringing about action. Then only God can save you if you insist on using such methods for studies. Understand, you will find that you have amazing recall. Right, so we've got our concept. Now let me add muscles to it. Again, come here, you can see sartorius, iliacus, psoas major, all those femoral triangle related muscles. Therefore, what will they do? Flex. Behind here, I can see gluteus maximus and hamstrings. What will they do? Extend. My adductors here, what will they do? Adduct. Gluteus medius and minimus, what will they do? Abduct. Got your 4 easy muscles actions and muscles bringing about actions. This is easy. Little bit difficult is who will bring about medial rotation, who will bring about lateral rotation. When this happens, try and remember if the structure lies anterior to the axis, it will medially rotate. If the structure lies behind the axis, it will laterally rotate. So now gluteus medius is assisted by sartorius and tensor fascia lata, which are lying anteriorly, to bring about medial rotation. Piriformis, gemelli, quadratus femoris, which are lying posteriorly, are strong lateral rotators. Maybe this is the only part which you will really have to mark up. Okay, initially. Later on, logic will come into play. So this is how you should use logic and some methods to understand and remember muscle actions. Right. So we've done relations, movements, muscles bringing about movements. You remember why I coupled them together? Because they are one unit. Let's now go to blood supply, nerve supply, and applied anatomy. Blood supply, put big stars to it. In case you're writing, put big stars to it. Very, very important. Clinically, this is what is needed for you to know. So now let me take you back to blood supply of the hip joint. Here you're seeing the branch of obturator artery entering into the head of femur through which ligament? Through the ligament of femur or ligamentum teres femoris, supplying upper 1/3, see I've written it here, upper 1/3 of head of femur called fovea capitis. Now this is an anastomosis of medial circumflex femoral, lateral circumflex femoral and gluteal arteries. I think you should be able to tell me what this anastomosis is called. Can you? Yes, it's called as the trochanteric anastomosis. From this anastomosis, essentially from medial circumflex femoral artery, branches ascend upwards to supply the head of femur. These ascending branches are called as retinacular arteries. I have taken this in my first lecture also. Because it's so important, we are repeating it. Come back to the diagram now and see what is the question asked. What is fracture neck femur? When will you see avascular necrosis of head of femur? Right. So now you are seeing obturator artery and retinacular arteries. Now let's fracture this femur. I think that's going to be fun, isn't it? So what are the types of femur fractures you see? You see a subcapital fracture. Please observe this here. See the subcapital just below the head of femur. There can be a transcervical fracture and there can be an intertrochanteric fracture. Now I have a question for all of you. Observe the diagram and tell me in which fractures are the retinacular arteries damaged. Look at it, come on. So, the retinacular arteries are damaged in subcapital and transcervical fractures. That means if this is where the femur is fractured, retinacular arteries are cut. And therefore, you have to have some kind of intervention. You cannot have natural healing of this fracture because head of femur has lost its blood supply and is therefore now going to go into avascular necrosis. So, retinacular arteries anatomy is very relevant. It's very important if you have to one fine day talk about fracture healing at the neck of femur. Got it? Okay. So students, if you're enjoying this lecture, please like and subscribe. Do share your thoughts in the comment section. It helps me to understand what more I can do to make these lectures of use to you. Right. Let's now talk about nerve supply. Again, madam, how do we remember all this? You put up all these 4 types of nerves and how are we going to remember? Come back to the famous fist. There was a nerve from the front, there's a nerve from behind. There's a nerve from medial, there's a nerve from lateral. Common sense. Anterior nerve will be a branch of femur. Basically, it's the nerve to rectus femoris. Posterior nerve is nerve to quadratus femoris. Medially, which nerve do you get in the medial compartment? Obturator nerve. So, a branch from obturator nerve. And what is the nerve supplying gluteus medius and minimus? Superior gluteal nerve. So, these 4 nerves supply your hip joint. If you apply logic, it's very easy to remember. If you are going to mug this up, then you are amazing. I am not. I cannot mug up. I only want to use logic because that's how human body works. Okay? Fist, anteriorly, nerve to rectus femoris. Posteriorly, nerve to quadratus femoris. Medially, obturator nerve. Laterally, superior gluteal nerve. All these nerves give branches that supply your hip joint. Okay? Right. We are in the last phase of this class now, students. Let's talk about something called referred pain. I think that was taught you in your general anatomy when 2 separate structures carry sensation to the same place in the spinal nerve. The pain from one can be interpreted as pain from the other. I think you already know this, so I won't elaborate on it. But the hip joint, the nerve that supplies the hip joint, also supplies the skin in front of the hip joint. So if you have hip joint pain, you often feel that the front of your thigh is paining. Actually, the pathology is in the hip joint. This is first referred pain. Similarly, obturator nerve supplies your hip joint. It also supplies your knee joint. So your patient might say, hip joint is paining, but my knee joint is also paining. Why is that so? Because of the concept of referred pain. There is nothing wrong with his knee. Okay? But this is the idea of how the brain misinterprets the pain signals which are coming from the body. Right. Now, the last bit of applied anatomy, we know that the normal angle between the neck of femur and the rest of the femur is about 130 degrees. Okay? When it's less than 120 degree, the condition is called coxa vara. When it's more than 135 degree, the condition is called coxa valga. This is interesting. Can you tell what has happened here? I know it's not a reason to smile, but as an anatomist, I love the fact that these things happen and they're interesting. In the first image, you can see the femur is inside the acetabular cavity. In the second one, you can clearly see the femur has got out of the acetabular cavity. But this is congenital dislocation. This has happened in a young child, okay, at the time of birth. Why does it happen? See, this is a condition seen commonly in female children. The capsule surrounding the joint is weak. The acetabular shelf, now note this, over here you can see a well-developed shelf. Here you can see a poorly developed shelf. The shelf, the femur rests on the shelf. When the shelf is weak, the femur pops out, okay? And now the femur is in the child's gluteal region, okay? So how does the child present? The child presents with an inability to abduct the limb. The limb looks slightly shortened and the whole structure, the shape of the gluteal region is dissimilar on both the sides, isn't it? So this is called as congenital dislocation of hip. It's not an uncommon condition. You have to know about it. One question, what is Ortolani's test? That's your problem. Find out. Okay. Traumatic dislocation of hip. Take a look. Oh God, what happened? Yes, the person has gone and hit a tree. The dashboard has hit his knee. Because the dashboard is hitting his knee, his entire femur has gone backwards, popping out of the acetabulum. This is called posterior dislocation of hip joint. It's a type of dashboard injury. This posterior dislocation can be associated with a fracture of femur, with a fracture of acetabular rim. Or it may not be, it may just be a dislocation. You can also have massive anterior dislocations, massive central dislocations associated with bad injuries. Okay? But here I have a question for you. If this is dashboard injury, is there any other dashboard injury? Yes? Yes, there is. Anybody who's done the knee joint should be able to answer this. It's a PCL injury, posterior cruciate ligament injury, is also called as a dashboard injury. When I teach knee joint, I will be discussing this. Fine. So now understand that it's very difficult to examine somebody's hip region. The hip joint is so deep and is so much surrounded by muscles that it's very difficult to actually palpate it. How do you examine such a joint? You have an X-ray. So you can examine it by using an X-ray. Just understand that when you draw a line from the anterior superior iliac spine to the patient's ischial tuberosity, it must pass through the greater trochanter. If it doesn't, there is a problem. Second line is, draw a horizontal line from the anterior superior iliac spine and greater trochanter. The distance between these must be 5 cm, not less, not more. If less or more, there is a problem. Finally, take an X-ray. Okay, you have what is called as a Shenton's line. The curvature between the lower end of femur and the superior ramus or pubis is one smooth line. You can see it here. Sometimes it is broken in an X-ray. This is indicative of fractured neck femur. This is called Shenton's line. Right. So now I have, how is it that the hip joint is stable? What are the factors that bring about stability of the hip joint? One are bony factors. That means the beautiful acetabulum and the head fitting well into it, good congruency leading to good stability. Acetabular labrum itself, which grips the head of femur well. The capsule, which is very strong and holds the two bones together. Accessory ligaments, iliofemoral, ischiofemoral, pubofemoral, and many others. And very strong muscular support. All these make for a very strong and stable joint, the hip joint. Then, why are we talking about stability, ma'am? We're talking because there is another unstable ball and socket joint, isn't it? The shoulder joint. Let's compare them. In the shoulder, it's the same kind of ball and socket joint. Here, the stability is sacrificed for mobility. It is way more mobile, but you don't really want to walk on your hands, right? Because you know very well it's not a stable joint. Okay, it's very mobile, the shoulder joint. The hip joint is comparatively less mobile. You really can't do everything that you can do with your shoulder. You can't do with your hip joint unless you're a gymnast. The glenoid cavity is very shallow, whereas the acetabular cavity is very nice and deep. Finally, the head of humerus is not congruent with the glenoid cavity. The head of femur is very much congruent with the acetabulum. So this is a comparison between shoulder joint and hip joint, asked in vivas very often. Do study this too. So what have we studied? Today we studied relations, movements, muscles producing movements, blood supply, nerve supply, and applied anatomy. This was hip joint 2. In my earlier lecture, I have covered classification, bones, and ligaments of the joint. Do go and watch hip joint 1 as well to have a complete understanding about this topic. I've given the link for hip joint 1 in the description section. If you've enjoyed this lecture, students, like and subscribe to the channel. It will encourage me to create more such videos for you. Thank you, students. I completely enjoy taking this class. I have one little message for you. Your dear Shakira, she says hips don't lie, isn't it? So understand that if you don't know hip joint, you definitely can't lie through it. You have to know the joint. Okay? So if Shakira is giving you a message, so am I. Thank you, students. I enjoyed taking this class. I hope you enjoyed it too. Thanks.